sensation was 0 before surgery, but after almost more than 3 years of surgery, the sensations have come to 25 millimeter in the cockade-banded actiometer. So another imaging technique is the in vivo confocal imaging system, which allows the quantitative and qualitative and quantitative assessment of the corneal nerves, gives us an idea about the nerve density, tortuosity, angulation, thickness, and reflectivity. This is one of the paper where you can see that the figure A represents the healthy cornea, where there is a good density of corneal nerves, but the other B, C, D, E, F, G, H, they are those taken from the unhealthy corneas, which are poor corneal sensation, either due to inflammation, surgery, ocular neurosurgery, or multiple intraocular surgeries, or herpetic keratitis. So you can see that the sensation, the nerve density is markedly less than what is seen in figure A. In cases of symptomatic neurotrophic keratopathy, this was one paper where the presence of microneuromas has been documented. The management includes medical, surgical, non-surgical, and surgical. So this is one of our paper, which is I'm really glad to say that this has got the IGO Merit of Paper Award of 2022, and this I would recommend everyone to go through this paper, because it comprehensively explains, gives a review of the literature, review of literature, and the the intermediate report of neurotization in the 7 cases that we had done initially. So the stage 1, essentially the treatment goes in a step ladder pattern in stage 1, 2, and 3. So in stage 1, mostly the treatment would include constitute a discontinuation of all topical medications which we think that they are going to cause neurotrophic or cause the sensory nerve deficit, and evaluate the side effects of the systemic therapies. Topical preservative-free artificial tears, even though they are very less, it is not very widely used, but at least in these cases, we should try to, we should prescribe topical preservative-free artificial tears. Coexisting conditions like exposure keratitis, dry eye, limbal deficiency should be addressed, and the eyelid dysfunction should be taken care of. Stage 2, apart from the discontinuing topical medication and prescribing preservative-free, we can also consider autologous serum eye drops, either 20% or 50%. There have been literatures where this has worked, and consider prescribing scleral contact lenses for these patients. Tarsography work wonders, because even temporary tarsography can help in stepping up the healing process. Other than that, amniotic membrane transplantation and botulinum toxin. Stage 3, you may require a tarsography and a conjunctival flap to cover the defect. Topical collagenase inhibitor to prevent the stromal from melting down further. Small perforations can be maintained by TABCL, amniotic membrane, and a tenon patch graft. Large defects require lamellar penetrating keratoplasty. So this was a case of herpes simplex keratitis, which come with a thinning. I do not have the pre-TABCL photo. So we had put a tissue adhesive, that's a cyanoacrylate glue, and whenever after 3 months, when we removed the tissue adhesive, it again leaked. So we had to replace the TA, and finally we had to do a graft because it has totally melted, and I do not have the post clear, but the graft remained clear for almost 1.5 years, and then the patient came with a large defect and a melting and infiltrate. So the graft resolved, but then we can see that it's a large graft that we had done, and there are areas of melting and uveal show. So amniotic membrane, this is again one more large graft where the epithelial defect was persisting and it was not healing. So we tried putting a large amniotic membrane and suturing with a tenonylon sutures, and doing a tarsography. So this was the patient with a fungal ulcer. We did a large graft, and this was the epithelial defect. It was not healing with whatever medications we were giving, so we did a amniotic membrane grafting, and subsequently it healed. So sometimes multi-layered AMG also helps. This was a patient where we did a we had to put multiple layers of amniotic membrane grafting to heal the process, and this is how it looked after 3 months. Tenon's patch graft again, when you do not have an access to amniotic membrane grafting, or you do not have an access to a fibrin glue, sometimes it works well. You have to remove a small part of the tenons from the patient's own tissue, and you can put a figure of 8 sutures to secure it. So this is how it will look at the end of the surgery. This was again a very young girl who came to our OPD with a herpes infection, HSV infection, and we were managing the patient on conservative management because the vision used to be 20/50, but 20/30, but she had this faint scar in the visual axis. One fine day, she came with a large perforation, and we could not do anything, and it was right in the visual axis. We had no choice but to do a penetrating keratoplasty. So this was the photo, but again she came back. She, during the COVID time, she had stopped the steroids and she came with a graft rejection, but again the graft rejection resolved with proper management. So now this is the talk of the town, that is the topical recombinant human nerve growth factors, Cinegermin 0.002%, which is now available. I mean, has been widely used, and which is approved as by the US FDA for treatment of neurotrophic keratopathy. So we can see in this article that the nerves have really, they have populated, and they have now the density is as normal. So so what do we learn from all this? The whatever techniques that we have, or whatever solutions or management that we have discussed, the somehow the underlying issue of corneal anesthesia still remains unaddressed. So that is also a possibility of need for a lifelong medications, because the patient will need lubricants, because we are not addressing the primary issue, and there is always a risk of recurrence. For this, the neurotization technique, which will be discussed later by my colleagues also. So this is this challenge, the previous challenge with the previous modalities have been addressed by a surgical technique which is called as corneal neurotization. It is a technique where the donor nerve graft is used to re-innervate the diseased cornea. It can be performed by two methods, the direct method and the indirect method. The direct method involves the direct transfer of the donor nerves to the corneoscleral rhombus to re-innervate the pathological cornea, and the indirect method involves an intermediary nerve graft that connects the donor sensory nerve to the diseased cornea. So I have a video, but I think I'll play it later. So neurotrophic keratopathy is a sight-threatening corneal pathology. The underlying cause has to be determined. Management depends on the stage of the disease, and it follows a step, and we can follow the step ladder algorithm for a better outcome. Medical management, it aids in correcting the symptomatology, but not the underlying cause. And neurotization is the definitive option in correcting the underlying pathology. Thank you. And I would invite Dr. Merle to present her.
Anyone in the audience doing neurotization procedures here? Anyone who's interested in doing them in the future? Okay.
So I'd like to ask the audience, how do they manage these kind of cases when you see stage 1 or 2 or 3? How do you manage such cases? Dr. Samrat, we'll start with you.
Doing everything except the
So what is your preferred technique? Like, how do you decide whether to do an amniotic membrane or a tendons graft, or
So it also starts off with the stage and stepwise again. So if something is So my favorite is if I know that the underlying cause is neurotropic, like say post some surgery, post RT and all, and if there is a exposure and there is a PD or something like that, my first would be is to do a tarsography. Say 95% of that takes care of it. The other 5% that is not there is the one that's more challenging. Then probably I'd go in for a AMG, and if there's a perforation, then first just try to manage it with cyanoacrylate. If it's very large, then I've done multi-layered also, and later on tenons also. And but tarsography is my go-to. Like first would be tarsography, and of course then lubrication. And I'm not going to those details. I think tarsography still works on the
Yes, yes.
but because it doesn't address, as you rightly pointed out, the underlying cause.
Yeah, but this is being seen. Okay, right. So we've just gone through a very interesting talk on neurotrophic keratopathy and how we manage it medically until we found out that there's a surgical way which we can do it. And so I'm going to talk to you about the principles and evolution of corneal neurotization. So Smruti alluded to the fact that the corneal nerves they come from the trigeminal, the ophthalmic division, and they lose their myelin as they enter into the stroma, and then enter into the epithelium, and there are multiple plexuses, and you can see that here the subepithelial, the subbasal plexus of nerves that we have. This is how it would look if you could actually show the entire cornea with the nerve plexus. This is a subbasal nerve plexus that we have, which forms a vortex here, and the cornea is the most highly innervated structure in the body. Okay, so it has about 1,700 more nerve fibers than anywhere else, and therefore is extremely sensitive. So what is the importance of the innervation? Basically, it's responsible for maintaining ocular surface homeostasis. So the tear production as well as the epithelial regeneration are the two components that actually help to maintain a good ocular surface. In the absence of either one, the surface breaks down and we have problems. So how do the nerves contribute? So the nerves are responsible for secreting substance P. They secrete calcitonin gene-related peptide, and this is helping in the epithelium proliferation as well as healing. The epithelium, on the other hand, when it's intact, secretes neurotrophin 3, neurotrophic like nerve growth factor, ciliary neurotrophic factor, which are important for nerve survival. So you have the nerves which will secrete substances which help the epithelium, and the epithelium which secretes substances which help the nerves. So obviously if the nerves are damaged, the epithelium is going to break down. We also have glial cell derived neurotrophic factor, EGDF, which helps in epithelial cell regeneration. And in addition, there's the reflex that we have, the blinking reflex that we have with an intact nerve pathway, as well as the fact that you have a autonomic supply to the lacrimal gland which helps in lacrimation, all of which are responsible for maintaining an intact ocular surface. So if any one of these breaks down, you have a problem with the surface regeneration, and then you can have issues which Smruti alluded to. So coming back to how did this start? So it was Dr. Samy in 1972 who first described indirect corneal neurotization. Subsequently, nobody used the technique, and then Dr. Terzis described direct corneal neurotization, where a huge frontal flap was made and was folded down. The nerves were identified and then brought onto the ocular surface directly. But then that is a very involved technique which requires the help of a plastic surgeon, and it involves reflecting an entire forehead flap. So right from the corona, the flap is brought down and you expose the nerves, and then proceed to make that go underneath the brow, and it comes into the fornix, into the subconjunctival space, and then it goes around to the cornea. So that's a very involved technique, and it has its drawbacks which I'll allude to later. So subsequently, Dr. Elbaz described a minimally invasive technique, an indirect corneal neurotization, which Smruti also mentioned, where you take a conduit from some other part of the body, and that is connected to a nerve on the other side, and then that is brought into the fornix of the affected eye. And this could be done in a minimally invasive way, which I think Dr. Rajesh would cover, using endoscopic techniques to kind of get the nerve into the area that we desire, as also for harvesting. And we are also able to use processed nerves, that is acellular nerve grafts, that is allografts. So all this while we've been talking about autografts used from the patient's own tissue, but then we are also able to get allografts. Not sure if that's available in India. Maybe Rajesh can guide us with that part later. But the autographs are what we are currently using in the surgeries that we do. So you have direct neurotization, where you take the nerve directly to the affected eye, which could be from the opposite side or sometimes a branch from the same side. And you have indirect neurotization, where you have the nerve which is functioning on the opposite side. You take a conduit, and I'll show you some pictures of that so you can understand further. So indirect, so indirect, you have the supraorbital and the supratrochlear nerves, or the infraorbital nerve, which could be used, where if this is the affected eye, you take the nerves, both of them, and direct them under the brow and into the fornix, and then this is fed around the cornea. Or you could take either the supratrochlear or the infraorbital, or a branch from the supraorbital, and then you bring that into the affected eye. It could be done for both sides as well, depending on how much of the sensations we still have. For indirect neurotization, obviously, because when you take a branch from, it's more involving, you require a long enough length of that nerve to reach that area. If you can take a nerve from, say, the sural nerve, or you can take a branch from the great auricular nerve, or even from the great occipital behind. And the advantage of using the sural nerve is the fact that it innervates a sensory innervation to the dorsal part of the foot. It's a very small area which doesn't actually trouble you if you take the nerve out. And it's also easy to harvest that nerve. Its diameter is not too great, so that you don't have problems with coapting the two. So you don't have a very broad nerve and a very small recipient branch, to attach it to. So you can take the sural nerve, connect it to the supratrochlear, and then direct the sural nerve into the fornix. And we'll be showing you the video subsequently to show how that is. So these are interpositional allografts or autographs that can be used. So how do you coapt it? So you have the supraorbital branch, which is a branch whose thickness kind of almost matches that of the sural nerve. And that can be coapted either by end to side, as you can see here, where you make a small window in the epineurium and you connect the sural nerve to that window and allow the fascicles, finally what the axons will grow through that. It's just a conduit. It serves for the nerves to grow through. Or you can do an end to end. So you connect the two nerves together, sural nerve to the supraorbital or the supratrochlear. Supratrochlear is a little thinner than the supraorbital and has lesser number of fascicles. So the supraorbital is what we prefer. And you have, you connect them epineurium to epineurium, just suturing on the outside, taking a lot of care not to damage the nerve bundles inside. So that is end to end. So what would be the advantage of an end to side? Obviously, you're still retaining some sensation on the forehead part, because you still have some nerves which are functioning, and only part of those nerves are traveling through this conduit to reach the eye. While when you do an end to end, you're using all the nerve bundles from that nerve. So therefore, the sensation on the forehead is going to be sacrificed. And that can be a problem for some patients. So this technique involves a contralateral nerve transfer, like I showed you, where you take the nerves from the opposite side and you transfer them. The bicoronal incision was what was done initially, and now we have moved to minimally invasive. So how does the outcome get affected by this? So as early as 3 to 8 months, there can be improved sensations going on, up to 3 years, 4 years down the line. The forehead numbness, which is there, which I mentioned, because obviously you're going to take a nerve and remove it from its original site of innervation and direct its neuron somewhere else. So you get some kind of numbness on the forehead, which is there for about 3 to 9 months, and the collaterals will grow in and cover that. But with this direct method that I was talking to you about, where the forehead flap is brought down completely, then there are risks of subgaleal. There'll be hematomas in that area, there could be neuromas, and there's obviously going to be some amount of alopecia and scarring, which is cosmetically not good, particularly if you're doing a full frontal flap and trying to do a direct transfer. So the ipsilateral nerve transfer is something we can do, where we take a small branch, as you can see here, and transplant that to the affected side. And you have the interpositional nerve grafts, like I was talking to you about, where you use branches of either the sural nerve or the great auricular nerve. But what is important when suturing it is that we should avoid tension on the nerve. We should be very careful when harvesting the sural nerve, and Dr. Rajesh will cover that part. We should avoid pinching the nerve, avulsing the nerve, damaging the fascicles within. And there could be the formation of some neuromas as well. So how does this actually work? So there are two theories. One is that there is release of nerve growth factor by the donor nerves, and there's direct sprouting of axons. And there was some evidence to show that when you stimulate the affected cornea, there are sensations which are felt on the contralateral side. There have been people who've done just a single case report on magnetoencephalography, where the opposite side of the brain records a response when you stimulate the innervated cornea. There have been rat models where they've looked at the labeled nerves and traced them back to the contralateral nerves. So you label the nerves in the rat, in the cornea, which has been innervated, and those labeled nerves have been traced back to the contralateral. So they say that there are some axons which are growing back from there. And what's actually happening is, and more believed, is that there's Wallerian degeneration happening when the nerve is transected. That leads to a Schwann cell dedifferentiation and proliferation, and the nerve actually just forms a conduit for the axons to grow into and innervate the cornea. But what exactly is happening on the cornea, and we've seen that there are IVCMs, in vivo confocal microscopy, that's been done, which shows you that there is some amount of nerve going back. But those nerves don't actually come back the same way as the nerves that we have with us. They are thinner, and they tend to have more myelin. So we read in, we heard in the beginning that the corneal nerves are all non-myelinated, which is important for vision. But these nerves don't lose their myelin so quickly, and they're much thinner and not as sparsely, not as thickly placed or closely to each other as the subbasal plexus that we have. They're thinner and more sparse. But they do the job, and Muralidhar is going to cover that in his talk on the outcomes. And therefore, in conclusion, this is a promising surgery for neurotrophic keratopathy. It requires a team approach. We'll cover that because, as you see, we have an oculoplasty surgeon in this, we have a plastic surgeon here, and we have a corneal surgeon. So it requires a group of people who work with these patients to get the nerves and for the procedure per se. It does have some amount of a learning curve, and we require much longer follow-ups, but we'll cover the outcomes in the subsequent talks. So thank you. I hope I've been able to cover something of what we do, and I'll hand over to Smruti because she's going to run through the video to show you exactly what it is that we do.
It's a video, audio. There's no video or audio. So we have discussed about the various techniques and of management. So this is our case of a 39-year-old female who had a history of herpes zoster ophthalmicus, and she had a history of recurrent corneal erosions and surface breakdown over the past 13 years, and corneal sensations were absent on the affected side. The same patient, pre-operatively when we are checking the sensation. A dental floss to check the sensation. After this we got the aesthesiometer. that the affected eye there is no sensation or absent of sensation. So this is harvesting the sural nerve from the left leg. The length is around 14 centimeter. Once we harvest the nerve, we have to determine. I mean, we have to keep it in a moist place, and we also have to mark the proximal end and the distal end. The proximal end is marked with a suture. This is the length of. I think we need a smaller graph than this, but since this was the first case, we did not want to fall short of the nerve. This is the isolation of the supratrochlear nerve from the healthy fellow eye. The first step is done by the plastic surgeon. This part is done by the oculoplastic surgeon, and this is making a subcutaneous tunnel by bluntly dissecting and connecting the subbrow incisions. That is the healthy eye to the non-healthy eye. The harvested sural nerve is passed from the left to the right subbrow incision through the tunnel. While we are doing it, we should be very careful. So we should not press or compress the nerve, otherwise it will lead to loss of neurons. Once this is done, then the appropriate size on each size of the eye is marked, and then we are making through the subbrow incision. The harvested nerve is passed through, and it is using the right facial medium brought to the conjunctival opening, superotemporal conjunctival opening. You can see that we are only touching the tip of the nerve, and that is how we are calculating the other position. The nerve is passed through the subtendon space till the limbus. And then it is divided into fascicles. Somewhere between 4 to 8 is okay. So for this case, we got 4 good fascicles, and through blunt dissection, we are trying to separate it from the sural trunk. Then 360-degree subtendons tunnel is made all around the limbus. These are the small pockets that we are making, just like an SICS tunnels into the limbus, about 0.5 millimeter into the limbus. So depending on the number of healthy fascicles that you have, you can make 4 or 6 tunnels equally spaced throughout the cornea. And then the fascicles are passed through these tunnels to the scleral site. Then it is trimmed as per requirement and inserted into the scleral pocket, into the cornea. Through the scleral pocket into the cornea. You can see that it remains like that. And then you can use a fibrin glue, or you can put atovicryl sutures to cover the defect. And then a tarsorrhaphy is done. At least for a month or so, the tarsal should be in place. Now this is the proximal end of the donor sural nerve. the tip of the nerve is pressured and it's cut, and then it is end-to-end coaptation. We can either do an end-to-end or an end-to-side coaptation with the supratrochlear nerve using a 10 nylon sutures. 10 nylon sutures. Circumferential puncture is done. The supraoral incision is closed and 6 nylon sutures. So adequate moisture should be maintained. Carefully, it should be handled. And this is the post-op 3 months. There is remodeling of the scar. There is no more epithelial defects since then. And I think I have the recent photos which I have not included. The sensation has also started. The patient has started regaining corneal sensation. And she's now able to feel the installation of eye drops. Earlier, she never used to feel that whenever we used to put the eye drop, but now she can feel the sensation. Partially, the corneal sensation has come back, but since she is a amblyopic patient, because all this had happened when she was in childhood, so we are not planning a penetrating keratoplasty further. But such cases, if they've crossed the amblyopic age group, there is a vision potential, then they can be a right candidate to undergo a penetrating keratoplasty. Thank you. We can take some questions if there is anything. I would request my co-instructor, Dr. Rajesh, to speak on nerve grafts. Thank you.
Those tunnels that you make, are they preferentially placed wherever your pathology was, or it doesn't? Okay.
And did you anchor the fascicles at the limbus with suture, fibrin, something? Yeah.
Entering from the scleral side till 0.5 millimeter into the cornea, put fibrin to secure it, and then suture it with fibrin.
On the sides. Yeah. So the the epineurium that is there has to be anchored to the limbus. You have to take care not to touch or damage the fascicles. So you tuck it into the pocket, anchor on the outside of the tunnel with fibrin as well as with 2 sutures on both sides, anchoring the epineurium. You can ask questions. You can ask whenever you want. Maybe during Murli's talk.
Because one is why is amplification of the primary the proximal part that will not be important. And second is that whether
sural nerve graft. Yeah. Can I ask? Yeah, sural nerve graft, there is no need to identify the proximal and distal end. It's not like a vein graft. Vein has valves, so we identify proximal and distal and reverse it for the artery. So the nerve is just going to be merely a conduit. So it's immaterial whether it is. Yeah. In fact, we don't even.
Second thing is that we know that nerves can like the major nerve supplies are 3 and 9, right? So if you have this passage instead of having it all around, so if you just have it at 3 and 9, does it make a difference?
Used to bring it on the 3 and 4. Okay. Small portion of the
entire plexus is
360.
The major fascicles are at 3 and 9.
That is the old transfer. That's what in a basic class, typically there is no wall in there. If I can put on a basic class. So that was the concept.
So we can do all 4. Right?
Yeah, and
That is all
yeah.
4 quadrants.
As many as
you can.
As many as
Yeah, because see, you've taken certain fascicles from the nerve, right, and those are being brought down into. So if you have very few, you may not have adequate innervation. You don't know how many of those are going to survive and actually grow. So the more you have, the better it would be. We work with 4 to 6. In rare circumstances, we've managed with less than that, but mostly we try to get 4 to 6.
And the last question is, can an oculoplastic surgeon do the sural nerve harnessing?
Yes.
Yeah, not without training, but we worked with them so often that in the last couple of cases they were just observing how we are doing, and it's as good as fascia lata graft. So once you learn the technique, I think it's doable. The instrumentation is unique, which he will speak about.
Good morning, everyone. Well, I'm a little different from the crowd. I'm a plastic surgeon, and enlightened by this opportunity that I get to work with my colleagues here and present it here. So, this is the hospital. So, luckily, we are just a a road end away. So, it's easy to go down to LVPI and then do the procedure. As plastic surgeons, we routinely handle nerves, and nerve reconstruction is a routine part of the armamentarium. And I'll just take you back a little bit to the anatomy. And when we see in the histology, so the nerve structure consists of, when you see the nerve bundle, any nerve bundle has a complete outer layer covering, that is the epineurium. And once you open the epineurium, you see several fascicles, which are actually groups of axons. So sometimes when you have, say, a nerve to the hand, in fact, one fascicle goes to the index finger, one fascicle goes to the thumb, one fascicle goes to the middle finger. That's how the topography has been designed by nature. And each fascicle is surrounded by a perineurium, and you have an endoneurium. This basic anatomy, and there are Schwann cells you can see. This basic anatomy is important for us to understand the principles of nerve repair. The gold standard is avoid a tension-free coaptation. Any nerve that is sutured under tension will give way, and you won't know the result. And whenever possible, we try to use end-to-end coaptation, whenever feasible. But if end-to-end is not feasible, there is no harm in using a bridging nerve graft. When you do an end-to-end repair, it's just one coaptation that the axons have to jump through, and the results are very good. And when you have a nerve graft, there are two junctions at which it has to jump through. There is always a number of axons that have passed and reached the final target is always around 2/3 of the original donor material. And the nerve graft is not going to really function or anything. It's just a conduit. It just funnels the entire axonal input into the effector organ without letting it go sideways. So these are the basic principles of nerve repair. And this tension-free coaptation is obtained by means of suturing only the epineurium to epineurium. Because if we go deeper, we have a high chance of injuring the axons. So we don't know what the result will be later. So this is we as plastic surgeons and all that. So the human body has two eyes, and there are great experts to take care of the two. And the third eye that we consider is the hand and the foot. So with the hand, we can really identify if there's a hard surface or if there's a soft surface and everything, if it is hot or cold. So that is all possible because of the nerve input into the hand. So this is a trauma case where there was a wrist cut injury and the ulnar nerve has been transected. And neurotization goes back to quite some history. And we have done an end-to-end repair with 8-ethylon here because you require a stronger suture. And by doing this, the nerve is going to grow from here into the hand and restore the sensations back in the ulnar nerve territory, which is this border of the hand, which is very important because when you touch anything, that is the first thing that rests. So whenever end-to-end is possible like that, we do end-to-end. So this is a patient who had a stab injury on the base of the thumb, and that was left, and she ignored it, and she had loss of sensations there, just like our insensate cornea. So we explored the wound, and we found that the radial digital nerve was in continuity, whereas the ulnar digital nerve, there are two digital nerves to the thumb, was transected, and there was a small scar neuroma as well. So there is no way that sensation is going to come back into this. The only way is to neurotize it. So when we cut the neuroma here, we are expecting a gap. And if we try to suture the two ends together under tension, it's going to break down, and we are not going to have the result of the sensation coming back. So this is now after complete isolation, and we probably have around a 2 centimeters nerve defect, and there's no way this is going to come together. So the only option is to use a nerve graft. So the nerve graft, there are various sites, but we chose the sural nerve graft. So this is an interposition sural nerve graft that is interposed between the two nerve endings. And once it is interposed and sutured with ethylon, and we superimpose, we strengthen our coaptation with some nerve glue. So we, instead of pouring it, we try to get the fibrin made and then deposit on top of it. And by putting this, we expect the sensations to come back. So what are the different sites from where we can take a nerve graft? Because nerve grafts are essential, we need to take them. Ideal donor site should be a sensory nerve, because you don't want any motor deficit. Suppose you take a muscle nerve graft and the muscle undergoes palsy, so therefore that is not expendable. We need a sensory nerve, and it should be expendable. So we can't take a sensory nerve from a very important area, say such as something that is from the hand or anything. So we want it to be an expendable donor site, so that is why the sural nerve is taken. And so the examples, and not only that, it should be long enough and adequate, because we are talking of targets around 7 to 8 centimeters away. So various examples are sural nerve, and as Dr. Smriti had shown, auriculotemporal nerve, which runs at the posterior border of the ear, and lateral cutaneous nerve of thigh, and etc. And we choose depending on the area. So the auriculotemporal nerve, we can use it for parotid surgery because it's contiguous, whereas for corneal neurotization, so our choice is sural nerve. So this is a sural nerve. This is a sural nerve graft harvest plan, where this I've marked the lateral malleolus here and the head of the fibula here. So posterior to the lateral malleolus, this is where the sural nerve runs. So the sural nerve supplies sensory distribution to the lateral border of the foot, as well as the fourth and fifth toes. And this area is somehow not really is quite expendable, because as in our country with wearing chappals, the most important point of sensation that we want is between the great and second toe, because to wear the chappal and to fit it there. So this is quite expendable, and we as plastic surgeons routinely take around the entire length, 40 centimeters, 35 to 40 centimeters of sural nerve, and both legs, because we require it for brachial plexus reconstruction, for multiple nerve reconstruction. So it is safe, proven technique. And instead of making a very long longitudinal incision, so we make multiple short incisions through which the sural nerve is easily identified in the subcutaneous plane, and then you take it. And it is done under tourniquet control. So that's why, as Dr. Smriti had shown, there is a nice avascular field. And the tourniquet does have its own limitations, because you need to be very careful in applying the tourniquet and deflating it, otherwise it can lead to permanent limb ischemia. So we prefer multiple small incisions, and not try to avulse the nerve, and try to keep it, try to preserve the branches. And regarding the direction, as well as sir has asked, so the distal end of the sural nerve tends to branch into a calcaneal and a sural branch. So the distal end is naturally branching. So we can actually keep the distal end towards the cornea, so it decreases our dissection, so we get more fascicles, more branches much more easily. Whereas the proximal one tends to be a common bundle, which can coapt to the supraorbital and supratrochlear nerve. So once the nerve, so this is the patient who has been planned for corneal neurotization, and as soon as I see this, so this is the right side that is affected. So my plan was, so the feeling that we get is, what is the donor? So the donor is the opposite side supratrochlear nerve, so which we have marked here. So so we check the sensations all right, our donor is good, and then this is our recipient. So there are multiple donors that we can choose. We have the supratrochlear, supraorbital, infraorbital. So infraorbital would run from here. We choose the supratrochlear and supraorbital because this area sensations are expendable, whereas if the infraorbital is taken, we compromise on loss of sensations to the upper lip, which is pretty important, especially when sipping hot fluids and everything. So the decision is made, opposite side supratrochlear for indirect, and this is as previously shown. So the nerve graft that has been harvested. So through here we have isolated the normal side supratrochlear and supraorbital bundle, and this is the nerve graft that is being tunneled. The amount of nerve graft that we take is, we measure from here till the limbus. So usually that translates to around 5 to 6. we keep around 2 to 3 centimeters extra and use that amount of nerve graft. And we don't tend to take more because it can be preserved back at the donor site. So once the nerve graft is tunneled through it, and here we can see that the supraorbital and supratrochlear nerve, they are very flimsy. So sometimes they don't tend to be very bulky. So we may need to do an end-to-end coaptation, because by doing an end to side, the amount of fascicular or axonal input is going to be pretty small. And from here through the opposite minimal incisions and through that tunnel into the eye, and so we have our proximal end there. What I'm holding with the left hand is the supraorbital. So this is the contralateral supratrochlear and supraorbital nerve bundle together, which itself is barely matching the sural nerve. So the nerve coaptation, this is the proximal nerve coaptation. We can do either proximal first or distal first. So if you do the proximal first, you can trim away the excess. So you can try to minimize the length of the nerve graft as minimum as possible. Because after coaptation, there is a temporary pause period of around 28 days. And after that, the nerve ends start growing through the coaptation. And the traditional way, what we see in hand is the recovery is around 1 millimeter per day. So in approximately 90 days, we expect it to move around 8 centimeters. So that means we have reached the target. So around 3 months later, we can expect some amount of axonal input into the cornea. And once the input is there, it has to go into the effector end organs, and that only gets better and better with time. So like here, the final step into the limbus. Once we try to put in as much axonal input as we can through this, so that the amount of recovery is at its highest. Because anyway, we have sacrificed a donor nerve there. We want everything to be channeled to this. We don't use a motor nerve for input, because classically the motor nerve input is not going to match, because we predominantly want only sensations. And neurotization is a time-tested proven technique in other parts of the body, like hands and sole, where we routinely use multiple nerve grafts and everything, and patients do get back not only sensations and even motor function of the hand. So it's very interesting that we get sensations back at the cornea. So the patient, and a natural healthy nerve ending produces its own nerve factors, growth factors, whatever its milieu that it wants, rather than what we want to supplement. So it's going to restore it's not going to function for one day, but keep on functioning till the end of the life. Yes. Thank you. Yes. Allografts are an option for people usually publish allografts for small digital nerve gaps, where instead of taking an autograft, it is readily available off the shelf and everything. Personally, I've never used it, because we know that autograft, the donor site morbidity is so minimal, and we can get it so quick, and the results are guaranteed. So autografts work excellent. Maybe in situations where suppose hand transplant is going on, and you definitely have a paucity, so because you need multiple cables for median, ulnar, radial, in such situations I think allografts will have their role, and they have been using them, but personally I do not have any experience with them.
So are they available in India? Do we have tissue banks that process these from
No,
donors?
I have not heard of any nerve bank till now.
Okay.
That's a good idea.
The allografts require some kind of rejection or something like that.
Yeah, that is a risk. So usually they try to decellularize it and preserve only the tubule, so that the antigenic reaction is kept at its bare minimum. So it's something like we have alloderm that is commercially available, where it is decellularized dermis. So something like that, without its Schwann cells and everything. But given an option, autograft, I would definitely choose autografts, because the donor site morbidity can be explained to the patient. And with adjacent creeping sensations, the loss of sensations is only temporary. After 6 months to 1 year, you see that the adjacent dermatomes overlap, and they no longer complain of that paresthesias on the lateral quarter of the foot.
Final question, maybe slightly stupid. Like all plastic surgeons are well versed in neurotization.
Yes.
So it's not something that require a special training or something.
Yeah. In fact, we take around 35 to 40. So it's in fact much more happier and easier for us to stop at 7 to 8 centimeters of nerve graft. And the coaptation is not very easy, so we need to make it, because unlike a vessel repair, you do a vessel repair, the result is immediate and apparent. If it blocks, on table, you can revise it. Whereas nerve repair, you need to wait at least 6 months to see your result. And if the coaptation is not proper, and if it has moved away, 6 months later, you just can't do anything later, because you have lost a potentially the most valuable donor nerve, and it has not got, you need to wait 6 months for your result, and you can't go back. Yeah, that is the allograft that we were discussing. So allograft we have not used till now, and it is an option probably in multiple, where you require multiple nerve grafts. So, and there is, you don't already sural nerve is used up or anything like that.
I think the technique of that you used putting the fibrin glue was very good, because I think I learned from you during the last couple of cases that we did together. So the way of putting both the fibrin and the thrombin together and making a blob probably kind of secures the graft instead of putting one after the other.
Yeah, we are very scared of nerve coaptation, because the result is not apparent, and we try to secure it as much as possible. So that we should not fail, because you just get that one chance. So I actually saw that technique from the Terzis. Julia K. Terzis is a plastic surgeon herself. So she was doing this, and I saw in one of her technique where by making that glue, it feels more secure, and you need to put less number of sutures. So
Thank you. Yes.
Yeah.
yes,
Baxter.
yeah, Baxter.
Rajesh, this end to end versus end to side, when we do that at the supraorbital, what's the difference? Like, is it a delay in the time taken by the nerve to grow, or is it that the spread also will not be that great if you have end to side?
When we choose the proximal
Right.
donor nerve, I think we will need a caliber that matches the sural nerve. So if we find the supraorbital and supratrochlear bundle to be pretty bulky, and it is almost up to the caliber and little larger than the sural nerve, maybe end to side coaptation may be better, because then you can make a good nick in the epineurium and do some controlled axonal injury. But if the end is already very thin and flimsy, then maybe better to do end to end.
So how do you ensure when you're doing an end to side that those fascicles actually go into that conduit that is on the side? So end to end, it's like given that they just go directly. But end to side, what do you do? Do you cut a bit of the perineurium of the most adjacent fascicle, or what?
Yes. So people say only epinural window, but definitely there is, you incise the epineurium, and some amount of axonal injury is created. Only then, so probably if you have a nerve with around 3 fascicles, you can sacrifice one fascicle, and then so that this fascicle, instead of growing distally, it will grow distally, it will also grow to the sideways. So there was a lot of debate on whether this will really work or not, because what if it doesn't grow sideways and grows entirely straight? But again, it has been time tested, because we use it in brachial plexus, where we use the ulnar nerve as a end to side to the nerve to the biceps, and it recovers. So even the ulnar nerve is kept in situ, and the biceps function does recover. So it is, with time we know that it will work.
So even the supraorbital part is also sutured by the plastic surgeon, the end to end.
Yeah.
Yes.
Yeah.
So how you all are doing it?
We both do it, and it's done under microscope, just like fortunately we have those sutures, the ones which they use for vascular and nerve repairs.
So it's all team effort. So unless the team comes together, only then it makes the entire effort very simple, and patient gets 200% out of it.
I think that's of the whole thing, to have a team from
Correct.
different organizations.
No, so at the end of it all, the plastic guys were like, oculoplastic guys, like, no, we can do this whole thing. We don't need you or them.
I think if you just do it once or twice, you feel that sural nerve harvesting is easy and you can do it. But then there have been cases where suddenly there's a deviation in its track, and that's when their experience comes in. So even if you know how to do it, it's good to have them for deviations, for complications, for problems.
Yeah, and I think we've seen variations in the anatomy of the sural nerve where it's
Yeah.
very, very thin, and then we would have been at a loss as to how to proceed
Right.
further.
Sensory nerves and sensory nerves are very diverse. Like they're not specific that they're going to be there, so they can have a lot of variation. So initially, it just gets a few cases to get the hang of it, because suddenly the most confusing thing is the vein is isolated instead of the nerve, especially under tourniquet, and you only realize it once you have detached it and removed it. So the vein is not going to work, and it's not going to make it. Obviously, when you see under the microscope, you'll see a lumen, so you'll discard it. So just a few cases of the hang, and medicine is all about overlapping fields. So everything, ultimately the benefit goes to the patient.
And I think the length of the nerve that you get onto the eye also should make sure it reaches all around the limbus. So I remember a case that I was doing where we didn't realize preoperatively that this patient actually had subconj fibrosis. So there was a nasal aspect where I could not dissect subconjunctivally adjacent to the limbus, and I had to take a fascicle all the way around the fibrosed area because I could not separate it. Otherwise, I had to go around that, and then kind of anchor it. So I was able to get only 3 tunnels into the cornea and put the fascicles in. So I think pre-op evaluation also, maybe Murli might highlight that when he's talking. It's extremely important to understand all those nuances too.
So I invite Dr. Murli. So he has been instrumental in gathering all the patients and the most
The
important
team
part of the
together.
team. So yeah.
Thank you, Dr. Rajesh. My part was much easier. I just have to connect everyone. A very good morning. It gives me satisfaction and a pleasure bringing
It's not on, I think. Murli, your mic is not on. Yeah.
Oh, yeah, I'm sorry. So this morning I realized my laptop has crashed. So I managed to get my old presentation. So hopefully it is relevant, and I've made some changes. It's not allowing me to save also.
It's better on this.
Yeah, well.
It's much better. We should invite everybody to come and sit up here and. Oh, that's you.
Any more questions in the meantime for the previous speakers?
Challenges that you get when you do your first few cases. I'm talking about those putting of those fascicles, because the nerve part I know is that going to be taken care of by
I think the dissection of the fascicles is the most challenging part, because subconjunctivally creating those pockets for it to go in, tunneling into the cornea is very simple. Dissecting the fascicle, because you have to be extremely careful that you don't injure each of those bundles. So you have to be very careful when dissecting. So that's what takes maximum amount of time and patience. Getting the adequate length, if the nerve that they've harvested and given us is long enough, you will get that adequate length usually. But then you should not have too much of tissue that is damaged at the edges, because then you have to cut that. So then you have to have enough to go around. But separating it into those good enough bundles which are long enough to go all around, that's what takes a lot of time initially. Something that's no, so that you hold the perineurium and you just tuck it. A little bit. Yeah. Yeah. Iris deposit. Yeah. No. No. Blunt dissection. Conjunctival scissor vanas.
Yeah, I shall be presenting long-term clinical outcome and both intra and post-operative complications. And this is how picture see, you have again a donor supratrochlear, supraorbital, where they've done a side to end cooptation, and you have your numerous fascicles. This number of fascicles is mainly depend on a bulk of sural nerve. If you have a very bulky nerve, would be able to get a good purchase. 5 to 6 branches are much more desirable, as Dr. Merle pointed out, and we need to bring it to subconjunctival plane all around. And if possible, I'll also show that video and make a numerous pockets, about 5 to 6 perilimbal or corneoscleral pockets. You could use one of the blunt, the crescent to achieve that one. You need to, put it into the cornea. The studies have actually shown if you leave it only in the subconjunctival plane versus if you make a micro tunnels into the cornea, the corneal sensations can be recovered as early as 3 months. So they've done a head-to-head comparison. So if you leave it in subconjunctival plane, perhaps it may take more than a year time to before it now sprout into the cornea. That also evident in the confocal studies as well. So I profusely thank our collaborators. Without their help and dedication, I don't think this project would have been feasible. Dr. Rajesh, Rambabu, and Dr. Gautam, they've really helped. Every time I say we have a workshop, they used to excited. And this is how theater looks like. Normally, as an ophthalmic surgeon, you don't like more than 5 people. You are very obsessive, right? So you have so many people inside the theater. So this is how collaborative team actually works. And a key person is Dr. Milind Nayak. So without his help, guidance, I don't think it would have been possible. And we also had some external collaborators who were actually technically watching. They were supposed to come, but they could not make it to the event, but we pulled it up. So without even prior experience, just seeing videos and interacting with external surgeons, and thankfully Rambabu, Rajesh had that ability to do the easy the neurotization. The way they did it was absolutely good. This was our publication. So I'll skip in the interest of the time. And a typical, this is a congenital corneal anesthesia. You can see a cornea is a dry, lusterless, and even when child cries, you provoke the child, you don't see a tears. And of course, once you have an epithelial breakdown, that is a rate limiting step. Once you have, the punctate epithelial erosion convert into something of this kind, then you have a cascade of events that also lead to the stromal melt. You will see a variety of these cases. One of the keys is recognizing these cases much earlier before even have any secondary changes in the cornea. They tend to have an extremely postoperatively good outcome. So this is what we, in our paper we just gave it based on the clinical findings. So some of these cases just need a supportive therapy. In terms of even a torsotherapy really works very well irrespective of etiology of a neurotrophic keratitis. And some of these cases can eventually get infected. So this way back Mackies have classified very elegantly. We follow the same thing. I think the first 2 variants actually have a very good improvement surgically compared to the the third group where you have already significant corneal changes. So we had a good robust protocol, inclusion and exclusion thing. I'll just exclude all this. So we excluded certain cases where we have any psychiatric issues, if they have other systemic diseases, debilitating diseases. And mainly we did an indirect neurotization, although Merle alluded to the fact that you have a direct and also great auricular now. And these were basically, initially we had some reservation about the Arpis zoster, but we did get a good outcome even a zoster. And systematically all these cases had a prior, and make sure the other eye when include in the study, other eye is at least normal, has a 20/40 or a better vision and free from any other ocular diseases. And also we have to make sure the donor, the opposite supratrochlear and supraorbital nerves, the sensations, everything is intact. So that's really important. And 2 of the cases where we consider this patient had a congenital corneal anesthesia. Although corneal anesthesia remained, But children, as they grew up, the systemic sensations recovered. We took a help of neurologists who did the nerve conduction studies. That's how the children were cleared for a surgery. Of course, we had a challenge in those two cases. So these were inclusion criteria. They were very, very strict and stringent. And we've excluded all site in these cases other than neurotrophic if they have any other systemic conditions. Now these are absolutely no. So we had so far 18 eyes of a 16 patient. 2 had a bilateral. We did at same setting, and mostly men, and nearly about unilaterality is a mostly. Perhaps this 4 is following a neurotrophic keratitis, perhaps due to neurosurgery, and 5 had some kind of a trauma, and 4 eyes of 2 children, little grown-up children, had a congenital corneal anesthesia, where we had a challenge of extremely thin, flimsy sural nerve, and we had only 2 branches. We could not dissect their fascicles, and that's what Mo was saying. We just have to do it at 3 and 9 o'clock. This is only 2 cases we did that. And herpes zoster we had 4, and 1 miscellaneous. We do not know what is the cause. Of course, herpes simplex was ruled out. And sensations improved in all cases, and earliest recorded sensations as early as 3 months, and one of the case which took nearly 18 months, one of this congenital corneal anesthesia. Even now we don't have a discernible corneal sensation we can document or demonstrate, but surface is doing very well. We could wean the patient of the torsorrhaphy. Apart from the surface stability, we did do the Schirmers. Schirmers did improve, and confocal was a direct evidence to show that neurotization is indeed working. And so is their visual functions. We could use a Coque-Bone in about 8 cases. Thereafter, we lost the instrument. So these were the confocal images. You can actually see at 1.5 years, you could see a subbasal plexus, which is almost comparable to the normal individual. This is a case of zoster ophthalmicus with no sensations preoperatively. You could see even this, the perilimbal thick sural nerve. Okay. And this lady did very well, and you could see although you don't have a much dichotomous pattern post-operatively, you could see a still wavy, thin, flimsy nerve fiber in the subepithelial plane. We've also looked at nerve density, dichotomy pattern, and beads. Beads are again indicates healthiness of these nerves. And this is one of the congenital corneal anesthesia, where I just have to post-operatively, you can see here, a sphincter I've expanded because I didn't want to do any corneal intervention. So with this opening, the child is, has a 20/40 vision now. We didn't have any intraoperative complication, at least in one case where it was a bilateral case, primary cause believed to be congenital corneal anesthesia, where we had a difficulty in identifying the supratrochlear and orbital. They had a difficulty differentiating between the vein and the nerve. So that's where their expertise came in, and we were able to sort that out. And as Merle pointed out, one case where I missed subconjunctival fibrosis, where we had a surgically, one has to be really good in surgical dissection and have a plan B in case plan doesn't work. Allodynia, this is an area where we've done a donor site that is a supratrochlear orbital. There are some, women particularly, they were mentioning about some tingling sensation whenever they comb, whenever they take a warm bath, so on, and that disappeared in about 6 to 8 weeks time. Beyond 6 months, nobody complained. And there are a couple of cases who had the leg sensations being absent, and I think that in about 6 months time, most of them recovered. Only one child had a delayed skin healing at the site of donor sural nerve, and at least we didn't have any complications even the donor site. And 3 cases had this. We used to use a vicryl sutures to close the conjunctival, subconjunctival space. They used to expose. Sometime you may have to prematurely remove them. And one case had a PED-like picture. This was again unilateral congenital corneal anesthesia. So that because tarsorrhaphy has come off post intervention, then I have to again put a contact lens, did the tarsorrhaphy, and within a week's time we saw a complete resolution. So to conclude, neurotization is a very, very effective surgical strategy in our armamentarium. To the date, we didn't have, particularly when it comes to neurotrophic cornea, although we had so many things in the last 200 years, right from supportive therapy. Tarsorrhapy is the only thing which used to work. Now I believe, you have alternative to tarsorrhapy. Of course, it is surgically very demanding and it is a team effort. And if you have a right case, I think you get a gratifying results by, all that, everything is worth, when you see the results of these, children's or patients. Thank you. If there are any questions, I'll be happy to take.
What is the minimum age of the child?
We used in our series 8-year-old. 8-year-old.
So in case of unilateral anesthesia, we are taking joining the graft from lateral supercochlear.
Correct.
What do you do in bilateral cases?
Yeah, bilateral, as I said, we took a neurologist's opinion. So we did a nerve conduction technique and we connected both supratrochlear, supraorbital. One is side to side, one is end to end.
One side is
But it was wonderful to see the long-term follow-up images with the nerve endings growing back. Because any other place in the hand and all that, we don't have any objective documentation. It's all subjective, saying the sensations have come back and all that. So it was nice to see.
Post-operative, you just keep a steroid antibiotic for a week's time and a steroid about 3 to 4 weeks time. The reason you have done a subconjunctival plane dissection, we don't want any subconjunctival fibrosis to happen. Okay, and you can use a plenty of preservative-free lubricants. So make sure that at least for about a month's time you have some temporary tarsorrhapy before innovation kicks in. So that's a time we have to be a little cautious. I don't think, yeah, we didn't use, I don't think it's.
So Murli, when have you knocked off the tarsorrhaphies and how many of them have gone off a tarsorrhaphy completely?
Can you repeat?
When did you knock off the tarsorrhaphies and how many have gone off the tarsorrhaphy completely? Because I'm sure they would have all had tarsorrhaphies before.
I think we had all temporary tarsorrhaphy. We didn't do any permanent, except these 2 cases, neurotrophic cases. Okay, all of them we were able to wean them off. We use a vicryl. It used to come off in 3 to 4 weeks.
Yeah.
And if the surface is good, we didn't again, go back and redo that.
Yeah. No, because most of them would have been on a permanent tarsorrhaphy before the procedure,
Correct.
right?
Correct.
So then their main concern then is the cosmesis, and this offers them a surgery. I mean, this surgery, though it's a very involved surgery, offers them at least the ability to keep their eyes open after that without having a tarsorrhaphy in place because the surface remains good.
I think one of the drive for parents or patients to go for surgery was that they will be free of tarsorrhaphy. So yeah, so I've convinced them tarsorrhapy may be needed for initial 4 to 6 weeks. Once healing is complete, then we can wean them off tarsorrhapy. So I'm just showing you. So this is how we generally make a sclerocorneal micro incision ports. We need about 1.2 millimeter. That is good enough to insert the entire fascicles. And as Dr. Rajesh was pointing out, we need to be very, very careful while handling the nerves. Should not produce any neurotomosis. Yeah, just about a millimeter into cornea periphery. You just need to step it, and we can also use that. So we are the surgeon is trimming up. So there may be nerve must have been nudged, must have been crushed. So if you could achieve about 4 to 5 such kind of peripheral nerve fascicles without creating a Dellin effect, we have to also be very, very cautious. If you have a thick nerve bundle in the periphery, can cause a Dellin. Unfortunately, we didn't have any stump neuroma, we didn't have any missing nerves. We were able to post-operatively track all the nerves. Yeah, no. We are overstay suture, taking a clear, so that nerve will not dislodge. If the eyeball is moving, so the nerve if the nerve is a little tighter, so it may actually slip from the pocket. We didn't want to, we just wanted to secure that. So now I'll invite Dr. Milind Naik. Yeah, we'll take the question. Sorry? Yeah, it is just stay suture. Stay suture. See that nerve doesn't slip. We're just placing, securely now. So
Variety of cases, right? So numbers were less for each. So of those, like the outcomes are better in each one, like the post-traumatic ones.
great question. Yeah, you're right. You're already answered my question. Yeah, post-traumatic, post-neurosurgery, excellent outcome. And Joster may be intermediate, and congenital corneal anesthesia, which these two cases had a systemic condition, they took a long time to recover. I still kept a one permanent torsorrhaphy. They used to have a bilateral, both the side, the 3/4 width torsorrhaphy. Now I just kept only lateral torsorrhaphy.
Case selection counseling is very important.
Correct.
So what are the salient points that we have to discuss with the patient before?
Now we need to know what is the drive for a patient to undergo surgery. Is the drive is a cosmesis or the vision, okay? And rest all secondary. Dr. Moll, you want to have had any silent points, is asking about, how do we counsel, what all points to be taken care.
I think they should understand that it's kind of a very involved surgery, very long surgical procedure. They will lose some sensations on the forehead, on the foot. They should be prepared for that, and the recovery time is long. You don't even know whether it will succeed. Like Rajesh was saying, if the coaptation of the supratrochlear supraorbital nerve, if it gives way, then the surgery is not going to work. So they should understand that there are risks involved, but then ultimately, if it does work, then they'll be relieved of the torsorrhaphy. Vision may improve. They'll have it's much better surface in those instances.
I request Dr. Milind Naik to deliver his talk.
We mostly covered all the challenges while the presentation was going on, so I think it will just be a repetition. So if there are any specific questions from anyone in the audience.
Correct. So as I showed you, Mackey's grading, even those who yes, we don't have, but my collaborators from Canada, okay, so Ali and group, they have done a corneal transplantation about 18 months after a neurotization, and they've also shown an histopathology. So the nerve was, grown into the cornea, and post-surgery, again, they've done a confocal. So those grafts are doing well without need of any torsorrhaphy or any other interventions.
What I would think is, suppose if it is a completely insensate cornea, so you do a corneal transplant as well, there's no way that the nerve endings are going to go. So once this is done and the nerve endings are there and you do a corneal transplant, so maybe they're just there waiting to go in. And regarding duration of surgery, maybe for us, we're microsurgeons, we routinely operate for 6 to 8 hours and all that, so with lunch in between and all that, so this is actually pretty not very long for us.
But still, as Samrat said, can we do it? Although we can do it, but it's best to separate these things into a team so that you only focus on what you are best at.
Yeah, since we did in a workshop mode 10 cases at a time, so that's very tiring, very demanding. Maybe if you have a 1 case or a 2 case, yeah, that can be easily manageable.
Sometimes having the team is getting the team can be a limitation in certain cases. So that's why I asked that question.
Yeah, if you club cases, no, it'll be great, because for him to be the entire day in the hospital, he has to harvest 2 or 3 patients, makes more sense than coming for one particular case. It'll be easy logistically.
We had clubbed 10 cases in 3 hours on one day.
I understand you're almost getting to task and probably didn't know the 10 cases last after you get consulted.
1 case or 10 cases, it'll take the same amount of effort, so you might as well club it.
Yeah, right. The team effort.
Exactly.
So my suggestion is take a clean cases initially, post-trauma or a post-neurosurgery cases. They are very, very good, easy to operate, and they have exceedingly good outcome. Because what patient reciprocate to you after a 4 to 6 months. So that's really important. We had one Bengal singer. She was conveying everything to Dr. Merle as well. She had the entire face also hyposthetic. She had acoustic neuroma removed some time back, and she has a very gratifying outcome. Her need for instilling medications had come down significantly. She was a professional singer. In between, she has to give any programs, she has to keep instilling medication. So now she's free of all medicines. So that's a good achievement in that case. Thank you. So
Participate.